Hello and welcome to today's niche webinar, Oral Health in Older Adults and in Acute Care Settings. I'd like to now introduce our speakers for today, Judy Haber, Ross Kerr, Mary Brennan, Kathleen Volman, and Hallie Ruppel. And we're going to start off with Judy. The floor is all yours.
Thanks, Corey. Welcome to the webinar, Oral Health in Older Adults in Acute Care Settings. This is a unique webinar that will focus on the oral health needs of older adults who are hospitalized in acute care settings and have oral health problems of a wide variety of kinds, some of which are complications of their primary health problem. But let's start with a bit of background. The Surgeon General's report in the year 2000 was the first report that really called to our attention the importance of oral health in relation to overall health. And in fact, the famous phrase, the mouth as a window to the whole body, is a saying that comes from that report. Didn't gain much traction for about 10 years, and then all of a sudden 3 IOM reports about the importance of oral health, the oral health disparities in our country across the lifespan, but those including older adults, were published within 2 years of each other and highlighted the problems that all adults and children, and particular older adults, have in accessing oral health care, particularly of a preventive nature or even of the kind that needs treatment. That oral health is a leading population health problem is highlighted by the fact that oral health is one of the top 10 leading health topics in Healthy People 2020. And there are specific oral health objectives for older adults in terms of decreasing their cavities rate, increasing their retention of teeth, and so on. So older adults and their oral health are really focused on in Healthy People 2020. This becomes increasingly important as a population health problem because by the year 2030, there will be over 72 million older adults in the U.S. Most won't have access to dental care, which will impact their overall health, whether in a primary care setting or an acute care setting. The fact is that there are many barriers to accessing affordable dental care. 70% of Americans 65 and older do not have dental insurance, and we know that Medicare does not have a dental benefit for older adults. There is a need to increase understanding for routine care. Almost 25% of older adults surveyed haven't seen a dental provider in 5 years or more. Some of this is due to the lack of ability to pay. As I said, 70% or 8 out of 10 uninsured seniors cannot pay for a major dental procedure like a new denture, a bridge, periodontal treatment, or the like. And although 33 million adults 65 and older do live where dentists and clinics are scarce, there has not been a tremendous consideration about the contribution that could be made by the primary care workforce, particularly in the area of oral health promotion and disease prevention, which is something we really need to consider. And so, as you can see, poor oral health and lack of dental care or oral health care in primary care settings can result in multiple overall health issues, some of which you are going to hear mentioned today. The IPEC competencies, the interprofessional education competencies, which were published in 2011, provide a huge opportunity for those of us who are not dental providers but are members of the nursing profession, the medical profession, physician assistant profession, to think about the contributions we can make as members of interprofessional teams in terms of improving the overall health of older adults. The HRSA report, Integration of Oral Health in Primary Care Practice, was an important document that was published by HRSA last year as the results of the work of an expert panel, which I happen to be fortunate enough to be on, that spoke about the contribution that can be made to promoting oral health across the lifespan, including in older adults, by the primary care workforce, and I'd like to extend it today to the acute care workforce. And if you think of starting by transitioning the HEENT, part of the history and physical exam that we all do, to the HENOT exam, when using that approach, that is the HENOT approach, you cannot forget about oral health in the history, in the physical exam, in the risk assessment you complete, or in the action plan that you put into place in terms of either preventive interventions or management within scope of practice, which of course includes collaboration and referral with and to our dental colleagues, and very important. So we'd like to suggest a wonderful resource for you, and there are many resources included in this webinar, but the Smiles for Life web-based curriculum is intended to be for interprofessional colleagues, dental and otherwise, including physicians, nurse practitioners, physician assistants, pharmacists, etc. And if you look at Module 8, Oral Health in Older Adults, it is made for all of us to watch, to think about, and to use, as well as Module 1, the oral systemic connection, and then, of course, the adult oral health exam module is in there as well. And you can earn more CE credits by completing each one of these modules. The other resource I'd like to point you towards is our Oral Health Nursing Education Practice, or ONEP website, which contains a wealth of oral health resources across the lifespan, and will feature our newest product, an interprofessional oral health faculty toolkit for those of you who are tuned in who are faculty who teach in nurse practitioner programs that focus on the nurse practitioner role in terms of taking care of older adults. So as I flip through the reference slide, I will pass the torch to my colleague, Ross Kerr, who will continue the presentation.
Hello, everyone. Can you hear me? All right. Thank you very much, Judy. It's a pleasure to be involved, and hello to all my nursing colleagues. So I'm going to talk a little bit about oral care in the older adult population in an acute care setting. So I'm going to move to my next slide. So you can see the topics that we'll be covering. I want to go to my next slide, and this is a report from the CDC that basically shows the different diseases for which patients are admitted to hospitals. And you can see that across the board, cardiovascular diseases are, comprise the greatest subset of patients that are admitted. And of course, there are other, diseases, pneumonia, sepsis. All of these patients in the older adult population are going to have significant underlying systemic diseases. And we know that many of them will have also significant oral diseases, and there really is a very strong association between oral diseases and the systemic diseases. And in the last sort of 10 years, we've been elucidating, some causation as well, so that patients with oral diseases are actually at a higher risk for developing systemic diseases. So, this goes both ways. Moving to my next slide. This is a sort of a fun little caption, and it really, shows you that we're really on the cusp of beginning to understand, the relationship of the body microbiome, and in particular for us, of course, the oral microbiome. And we're now able to really understand what the oral microbiome looks like in health. And as you can see from this next slide, these are basically, this is from the Human Microbiome Project. On the top, you can see, the different phyla, and below that, the different genera of different bacterial microorganisms and groups of microorganisms that inhabit the oral cavity. And there are different niches in the oral cavity that have a different blend of bacteria. And so understanding that is the first step to understanding how disease develops. And so the next step to this will be to identify the oral microbiome for each of these different oral diseases, and again, patients who have underlying systemic diseases. So it's a very exciting area, and because of sophisticated techniques to be able to identify these bugs, that used to be that you have to culture all the bugs, but now using 16S RNA, we can actually pick up all of the bugs and even more. We're learning about new bugs that we didn't even know existed. But it's not just about bacteria, it's also about fungi. And we know that, using these sophisticated techniques, we can actually find a lot of different fungal footprints that are occurring in healthy patients. And so in disease patients, we're going to see different fungal organisms. And of course, Candida, in this one study of healthy patients, shows that up to 75% of patients have Candida in their saliva. So moving along back into sort of the domain of the oral bacteria, we've all heard of the term, oral microflora or the biofilm or plaque. And so here is someone who clearly hasn't visited a dentist or hasn't a clue how to brush his or her teeth. And you can see this mat of oral biofilm, which has led to a very significant inflammatory response, which is illustrated by intense erythema along the gingival margin. And this is your classic case of gingivitis. And of course, in some individuals, that gingivitis, if left for long enough, progresses in terms of the inflammatory response, and as that oral biofilm matures over time, we get the resident pathogenic microorganisms tending to grow and proliferate, and then we get underlying disease, which is ultimately manifested as periodontitis. And periodontitis results from, these pathogenic bacterial microorganisms invading into, the local cells, causing an extensive inflammatory response, which leads to loss of bone structure. And you can see the difference there between a moderate to severe periodontitis in terms of the loss of bone. And as such, more of the tooth is exposed, you eventually get tooth mobility and then tooth loss. Moving on to the next slide, this is that oral systemic disease interplay. And we know in terms of periodontal disease that periodontal disease is implicated in a number of different systemic diseases. And the ones that are most, well established in terms of causation are really with respect to diabetes. We know that if you have an uncontrolled diabetic and you treat their periodontal disease, that their glycemic control is significantly improved. We now know that we have many of the tenets that would cause us to believe that periodontal disease is associated with cardiovascular risk is almost being established. Not quite there yet, but we're very close to being able to say that there is a causation there as well. and so a number of other diseases, and I know that we're going to be talking a little bit about VAP in a moment as well. So pneumonia is obviously important too. So moving on to the next slide, this is a patient, so we're moving on from periodontal diseases. This is a patient who has dry mouth, and these acute care patients notoriously have dry mouth. They're on multiple medications, and they present in an uncontrolled state. So these patients have a lot of dry mouth, and some of the things that you can look for are this, this enlarged sort of tongue, which has got a smooth surface. It's depapillated, and you can develop angular cheilitis because these patients are at a much higher risk for developing candida. Moving on to the next slide, we see a patient with a significant dry mouth that is developing dental caries and hypomineralization right at the gingival line. And it's subtle, but you can see this loss of enamel structure, and that's extremely important. Moving on to the next slide is another patient who has really much more advanced cervical decay, and this again is related to dry mouth. So we've got to be on the lookout for cervical caries, particularly in a patient who is polypharmacy or has other underlying diseases that would cause them to have a dry mouth. Well, as acute care nurses, you're always concerned about patients and their dentures, and of course, let's try not to lose the dentures. That's one of the main problems, is patients tend to lose their dentures, and but patients obviously present with dentures. They're either partial dentures or complete dentures, and of course, some of them don't even present with any partial dentures, and they have problems with nutritional issues, and that will also be covered in one of the next lectures. And of course, in patients with dentures, this is a classic denture stomatitis, which is a fungal infection, and this patient obviously isn't practicing careful denture hygiene, so that's something else that we can talk about in a few moments. This is possibly an immunocompromised patient population, so they may be at risk for developing pseudomembranous candidiasis. This is thrush. You can take a piece of gauze, wipe the area, that will wipe off, and that patient should be put on to antifungals. Patients who are older adults may be at risk for developing malignancies. And so here are some patients with one with a very advanced malignancy on the upper left, and then two others with very early malignancies. So if during your exam you do detect abnormal findings that are persistent, you can't explain why they're there, then it needs to be seen by an oral health care provider. And as Judy mentioned, we've gone from this concept of the HEENT to the he-not. You've got to include the oral in your examination. After all, the mouth is part of the body, even though I am rather embarrassed that the fragmented system that we experience here in the United States seems to avoid, considering the mouth as part of the rest of the body. Hopefully we can get back and make some progress in that area. And when it comes to doing an assessment of patients, there are all these different assessment tools. But the bottom line is, you don't really need one more thing to do and have to go through all of these specific assessment tools. This is something that is very easy to integrate into what you already do. And so the next slide, which is rather busy, shows the intraoral examination. We're assuming that you're performing an extraoral examination to look for lymph nodes and other asymmetries of the head and neck. But when you get inside the mouth, it takes no more than a couple of minutes to do a careful mucosal exam. What is important is that you have a good light source. And this little light that you see here, the little headlamp, can be less than $40. You can order it online, and then you've got a nice little headlight which frees up both your hands to be able to do a visual and tactile examination. Using a little pen light is fine. It's not ideal, and make sure that you use your fingers also to palpate the area of the mouth. There are many nooks and crannies in the mouth. It's not just about looking at the teeth. It's not just about looking at the tongue, but really pull away the upper lip, the lower lip, look at the whole sides of the cheeks, the buccal mucosae, look under the tongue into the floor of the mouth, and performing a bimanual palpation to palpate for any lumps and bumps that may be in the floor of the mouth. When it comes to performing oral hygiene, a toothbrush works very, very well. I do not advocate the use of the toothette. And I think that a soft bristled toothbrush works like a dream. And so when you're doing your toothbrushing technique, angle the brush into the gum line, little circular motions, brush every tooth surface, and spend some time doing that. Using the little interproximal brushes are helpful as well to get between the teeth. And then a couple more slides. When it comes to oral care, particularly in acute care setting, the use of things like chlorhexidine with a toothbrush using a suction tip, you can effectively not only clean the actual teeth, but you can also clean the mucosal surfaces at the same time. And there are also dedicated products to patients who have a dry mouth, to patients who have dental caries. There are high fluoridated content toothpaste. Denture hygiene, extremely important. Brush the patient's denture with soap and water. Make sure you keep it in the cup. And if they develop, fungal infections, make sure they keep those dentures out and only use them when they need to eat or during the day, and make sure they take them out at night. So that's it, a quick whirlwind lecture, and I hand it off to my next colleague.
Thank you so much, Ross. This is Mary Brennan, and I'm going to be speaking about nutrition, oral health, and systemic health in hospitalized adults, something we call the NOSH initiative. The subject of malnutrition in the hospital was brought to light in the 1970s when Butterworth wrote a groundbreaking report called The Skeleton in the Closet. Hungry in the Hospital followed that report. Unfortunately, not much has changed, and patients in the hospital are still hungry. There have been reports that up to 20 to 50% of patients are malnourished upon admission. Of those patients who are malnourished, up to 70% of those patients will experience a further nutritional decline. Up to a third of all patients, even those who are not malnourished, will experience a nutritional decline in the hospital. However, unfortunately, the nutritional status of patients is frequently underassessed, underdiagnosed, and undertreated. Most individuals do not recognize malnutrition in hospitalized adults. Profound nutritional deficiencies exist upon admission to the hospital. There are many factors that contribute to malnourishment before the hospitalization. Poor oral health is a significant factor. Patients without teeth or those who are missing teeth are frequently not able to consume a healthy diet. Their diets consist of more sweets, less fiber, fewer fruits, fewer vegetables, and the lack of a healthy diet contributes to more comorbid illnesses such as hypertension, hyperlipidemia, cancer, myocardial infarction, and stroke. The evidence suggests that an association between periodontal disease and pneumonia and diabetes exists. Individuals with dentures consume lower amounts of proteins as well as lower amounts of important vitamins and minerals, such as vitamins A, B, and C. These substances are needed to heal and develop new collagen after surgery. In fact, the body has a 5-time increased need for vitamin C for developing collagen and healing. Many factors in the hospital also potentiate the nutritional decline. Illnesses, infections, sepsis are often accompanied by a decline in appetite. As many of you know, patients are often kept NPO for tests and or surgeries, and oftentimes the tests or the surgeries are canceled day after day. Patients may go without food for 3, 4, 5 days. Elderly patients often experience a decline in their taste sensation as they age. However, this is even more pronounced in the setting of caries. There was an article that was written in the New York Journal of Medicine in the 1980s that was titled, "Nature Castigates Those Who Do Not Masticate." And it's so important that patients actually be able to chew their food. But many pre-existing problems exist. Tooth loss, dentures, periodontal disease, as Dr. Kerr mentioned, xerostomia, oral pain, mucositis. This all affects the intake of a healthy diet. Nourishing the GI tract is so important. As many of you know, 80% of our immune function is synthesized by the GI tract. If we don't nourish the GI tract atrophies, and the structural integrity of this barrier between the GI tract or the oral nasopharyngeal tract and the individual becomes compromised. This is important, as Dr. Kerr mentioned as well, because a number of organisms exist as normal flora. And if the patient becomes compromised, if the immune function is diminished, some of these bacteria actually translocate and cause infection. A perfect example is Streptococcus pneumonia, which is a normal flora. It exists normally within our bodies. However, when the individual is compromised, Streptococcus pneumonia is the leading cause of community-acquired pneumonia as well as hospital-acquired pneumonia. One of the most significant factors that contributes to a nutritional decline in the hospital is something called hypermetabolism. This is a stress response to injury. And individuals who have infections, who have inflammation, cancer, have a revved up metabolic response. This increase in the metabolism actually causes an increase in the caloric and protein requirements. If the body is not receiving enough protein, what happens is that we break down our own proteins, or the patients actually break down their own protein. What happens is patients can significantly lose so much of their muscle protein within a relatively short period of time. For example, if an individual with a serious infection like sepsis is not provided nutrition, they can lose up to 1 to 2 pounds of muscle protein per day. This not only contributes to serious weakness in the hospital, it actually contributes to very poor healing, nutritional compromise, poor immune function, etc. The responses are very significant. In fact, there is a 2 to 3 times increased risk of infections for those patients who are nutritionally compromised. Some of the most common infections, and actually some of the most lethal infections, Clostridium difficile enterocolitis is a common hospital-acquired infection. Surgical site infections, post-operative pneumonias are also occur with increased frequency. Patients have a 4 times increased risk of wounds, and actually it's interesting because they may develop spontaneous wounds as a result of not receiving enough care. So while everybody is, and nurses oftentimes are assiduously trying to prevent pressure ulcers, one of the most important prevention strategies is providing enough nutrition. There is a 5 times increase in major complications associated with common surgeries, such as a bypass operation. Those patients are at increased risk, 5 times increased risk of developing a sternal wound infection. Also, nosocomial infections, length of stay, and mortality, particularly in the elderly, are all increased. One of the most important strategies for preventing malnutrition in the hospital or for treating malnutrition is to make sure that we actually assess patients who are malnourished. One of the tools that has been validated in the hospital setting is the MUST tool. This is a tool that relies on 5 easy steps to assess the patient's nutritional status. Step 1, calculate the BMI. Step 2, look at the unplanned weight loss in the past 3 to 6 months. Step 3, actually, if the patient is acutely ill and unlikely to be fed for greater than 5 days. Step 4, calculate the overall risk of malnutrition and address each risk individually. So, for example, if an individual has a 2 or more on the MUST tool, they are at high risk of malnutrition and immediate action must be taken. The Alliance to Advance Patient Nutrition Treatment Strategies has really trumpeted a call to action that hospital malnutrition is a very serious problem and it needs to be addressed. They recommend 4 different strategies for addressing this, and one is the delivery of food and nutrients to patient much earlier. The dietary recommendations need to be tailored to the individuals. Elderly oftentimes have an increased need for protein to ensure that they have enough strength in the hospital. Patients with renal disease may have a lesser need for protein. Oral health and nutrition education is so important. NPs who perform fewer oral exams are those individuals who are often not as well educated as others. One of the Cochrane reviews recently looked at dietary advice without oral nutritional supplements or with, and they recognized 45 studies of varying duration, but the provision of nutritional supplements actually caused an increase in weight, mid-arm circumference, grip strength, and unfortunately no difference in mortality though. Here is one Cochrane review that looked at 62 trials, over 10,000 participants. The interventions were provided up to a maximum of over 18 months. In these patients, malnourished patients particularly, had a statistically significant decrease in complications. There were noted improvements in weight increase, mid-arm circumference, and also a decrease in complications. However, unfortunately, there was no change in the mortality or the length of stay. More high-quality studies actually need to be done and looking at this particular population. The Alliance Nutritional Care Model actually has 6 principles that they feel are so important in advancing nutrition and oral care in the hospital setting. First of all, we have to create a culture where nutrition and oral care are central to the care of all patients. This is very important. All clinicians need to be well educated about nutrition. It cannot be just the purview of the dietitian. All physicians, nurse practitioners, nurses, all have to collaborate and communicate on the nutritional care plan. We have to assess all patients at increased risk, and we have to rapidly implement interventions. Our discharge nutritional status also needs to be addressed. Lots of patients are discharged from the hospital without good discharge care instructions. I would say, just to summarize, everybody needs to be involved in the care of patients. We need to expand the hospitalist and acute care nurse practitioners' roles in leading the team. We have to have nutritionists, dentists within the hospital, and I would say upon discharge, these patients need to be evaluated for their oral health. Collaboration is a must. And now I'm going to send it off to my colleague, Kathleen Bowman. Thank you.
Thank you so much, Mary. I appreciate it. I'm excited to be here with you today to focus on the oral health of patients who are being ventilated, specifically those that have an endotracheal tube. But I would also ask you to consider that anybody who is at risk for microaspiration and is not able to eat, is NPO, has the opportunity of developing negative consequences related to not addressing the mouth. I do want to put forward, I have these disclosures. In the past, I've been sponsored to speak by these various companies, but I also think it's important for you to know from a conflict of interest perspective, in 1992, I brought a comprehensive oral care program into Henry Ford Hospital in Detroit, not just the ICUs, but the entire hospital, recognizing the importance of oral health. Before I jump into talking about the science, I've also discovered in my journey working with staff that if we don't put the context of fundamental nursing care in the place of patient advocacy and the nurse's role of patient advocacy, the staff may think of it as just one more task. And as Florence Nightingale said, it may seem a strange principle to enunciate, as the very first requirement in a hospital is to do the sick no harm. So there is no question in my mind that our advocacy role is not just about pushing up the chain of command or helping a patient understand. It is also ensuring that the preventative care strategies that are under the nursing domain are done to prevent that harm from taking place. And as a critical care nurse, well, when you think about how do we protect bad things from happening to humans on our watch, a lot of it circles around hygiene, which oral hygiene is part of it, and mobility. But working with both critical care and med-surg nurses, I found out that that's not very sexy. It's got to compete with the latest balloon pump, the newest cardiovascular drug. So I created a term called interventional patient hygiene. Yes, a little tongue-in-cheek, but also very serious in the fact that when we look at the definition of hygiene, it is the science and practice of the establishment and maintenance of health. So when you think about it, it really doesn't get any more fundamental than that. So when you put an action verb in front of it, what it says is I am proactively intervening with evidence-based hygiene and mobility strategies to eradicate 3 of the top 4 errors in this country: healthcare-acquired infections, falls, and pressure ulcers. It is a way more powerful concept than a single implementation of oral hygiene, yank the Foley, clean the butt, bathe the patient. It puts it into a stronger context. And for those of you who are pictorial learners, patient in the center, hand hygiene around, the light blue is fundamental nursing care activity, and the red is the nurse-sensitive outcome indicators. And as you can see, oral care and mobility are highly connected to reducing ventilator-associated pneumonia and hospital-acquired pneumonia, which is now the #1 healthcare-acquired infection in this country. So another part of this journey in understanding how these are not just viewed as tasks in our environment is, one, building the value as we teach this new evidence-based skill and knowledge. But the other, and probably the most significant part of this, is to ensure the staff have the right resource and the right system to make it easy for them to do the right thing every single time. And we've done this pretty well in critical care in the fact of having oral care kits that provide all the necessary treatment or prevention strategies in one place, and we have a way to then make assessments and ensure that the care is being delivered. But in most med-surg units in this country, the only thing the staff have to clean a patient's mouth with is a toothbrush that I'd probably only use on the grout in my shower, and toothpaste that has 0 therapeutic benefit whatsoever, Fresh Mint. So a lot of changes looking at that resource and system are going to be an important part of the journey of reducing ventilator-associated pneumonia in our ICUs and in our LTACs in this country. So we've made a significant reduction in VAP rates over the years. When we started this journey in the late 1990s, the VAP rate for burns was 15.8. It is now running about 4.4 per 1,000 ventilator days. Increases the average length of stay by 10 days, and cost per case is roughly around $40,000. Because of so many controversies in the VAP definition, we have now launched in the United States ventilator-associated events, which appear to correlate to mortality, hospital length of stay, time on the vent, much more accurately than the previous very subjective definition of VAP. So why is this so critical and significant? Well, these 2 studies, even though they were done a while ago, really cement the importance of the connection between the mouth and causing pneumonia. The study on your left, 89 critically ill patients, examined the microbiological colonization of the oral pharynx. They used pulse field gel electrophoresis to be able to compare that chromosomal DNA. 31 pneumonias, 28 of the 31, the DNA matched identical. There was this additional study done several years later looking at 49 elderly nursing home residents that were admitted to the hospital and intubated. They followed using that same technology, but they were going after the plaque, which, needless to say, the biofilm and the microorganisms. 14 pneumonias, 10 of the 14, the DNA matched identical. So if you're out there and you watch CSI or NCIS like I do, we send people away for life on DNA analysis. the mouth is guilty. Feel free to use that one. So we know from some of the work of Dr. Kalish's group that oral care is one of the most frequently missed nursing care practices in the hospital. So we have to make some changes. We are seeing in surveys that are done in the critical care with critical care nurses that 91% of the respondents perceived oral care as a high priority. But when surveyed in comparison to what the AACN policy stated, the American Association of Critical Care Nurses, which I took part in writing that policy, is that only 50% provided that oral care Q2 hours and 42% Q4 hours. They would brush the teeth twice a day and then would use a solution with a foam swab, but a foam swab that had a suction on the end of it to reduce any kind of microaspiration occurring. And as you can see, 61% use CHG as a part of it. So what does the evidence tell us? Should we just brush? Should we use just chlorhexidine alone? Should we use chlorhexidine in combination with brushing, swabbing, cleaning, moisturizing, and suctioning? Well, the answer clearly is all of the above. So if we look at a meta-analysis that was done looking at just chlorhexidine in the prevention of VAP, it does show statistical significance if you look on the very bottom here. That does not cross the mid-center line of the confidence interval, so it is statistically significant. But you can also see that there were mixed results in these studies. So I think the message that you can take from this is it's not just about twice a day in the mouth. The frequency at which we need to get in the mouth because individuals gather secretions plays a role in this. Also, I don't know if the studies are meeting our population. Again, the impact of toothbrushing. Basically, this meta-analysis showed toothbrushing did not make a difference. However, I very much appreciate the author's comment that there are not enough studies and we need to do a better RCT because in the dental world we have a ton of research showing the impact of toothbrushing. The challenge is, again, these studies were singular in the fact that they just looked at brushing 2 or 3 times a day and not addressing everything else in the mouth. So if you look at a conglomerate of the ICU oral care studies, a lot of them are before and after designs looking at comprehensive oral care with cleansing anywhere between 2 to 4 hours, suctioning as well, and moisturizing as discussed previously with that brushing twice a day with or without CHG and deep oral cleansing every 6 hours to get in the back of the throat, with reduction in VAP rates anywhere between 63 to 100%. However, the protocols have a significant variation within them. So if we're going to make this happen, it is clear that comprehensive oral care with some form of an antiseptic and cleansing in between is critical. And I believe this not just to be done with patients who are intubated, but any patient at risk that is unable to do their own ADLs. Create visual cues to be able to show evidence of the compliance. Sometimes our kits or our oral care products can do that themselves. What processes do we need to build to ensure that the right thing happens every time, included in our order sets and on our flow sheets? And also, if the product is easy to use, we may be able to teach the family and patient to assist if it's appropriate. So I want to thank you for the time, and I'd like to pass it on to Hallie Ruppel. Hallie?
Thank you, Kathleen. Hi, everybody. My name is Hallie Ruppel, and I'm a senior nurse clinician at NYU Langone Medical Center, and today I'm presenting on behalf of our Oral Care Council and our chair, Dora Castillo, who regrets that she can't be here today, and I'm going to talk about our oral health initiative at Langone Medical Center. So I have no disclosures, and my goal is just to describe our experience implementing an Oral Care Council. It's our 10-year anniversary of the council this summer, so I'm just going to talk about our experience a little bit. So I'd like to begin with a brief overview of the literature that we found to support our work. Certainly the presentations that you've heard so far this hour have really set the stage as to why this initiative in the acute care setting is so important. So hospitalized patients have compromised oral statuses. They're more likely to be colonized with respiratory pathogens. Intubation gives oral pathogens access to the lower respiratory tract. increasing the risk of ventilator-associated pneumonia, which we just heard about. And the evidence supports using multiple VAP prevention strategies, and one of these evidence-based strategies is proper oral decontamination. So in addition to mechanical ventilation, other stressors experienced by hospitalized patients impact oral health as well. Decreased oral intake, compromised immune systems, immobilization, and dependence on others to provide oral care, and some medications that also have detrimental impact on the oral mucosa. There also may be impairments to oral health that are actually already present on admission to the oral care setting, so related to pre-existing medical conditions, nutritional status, cognitive impairment, or functional dependence. And then finally, the CDC and the Health Infection Control Practices Advisory Committee recommend guidelines to reduce the incidence of pneumonia. And one of these guidelines is the development and implementation of a comprehensive oral hygiene program for patients in the acute care setting. I think we just skipped ahead there. Yeah, there we go, perfect. So, yeah, if you can go to that slide, there we go. So our Oral Care Council began back in 2005 when Dora Castillo, nurse administrator, noticed on her rounds just anecdotally to various units that oral hygiene wasn't routinely or consistently provided by the nursing staff. And at that time, Dora decided to form a small committee to investigate oral care practices and to standardize the oral care practices and products that we were using across the institution. Since 2005, we've grown from a small nursing committee to a large interdisciplinary council. We have monthly meetings, we publish a quarterly newsletter, and most significantly, I think, is that we've implemented and standardized oral care practices for nursing staff. So between 2005 and 2006, we surveyed our nursing staff and in order to evaluate the extent of oral care practices and documentation, and also to look at the current available supplies at the institution at the time. And in 2005, we found that the only available oral care supplies were those lemon glycerin swabs. We removed them from stock house-wide, and we replaced them with basic toothpaste, toothbrush, mouthwash, and oral care kits. The council developed oral hygiene nursing standards and implemented clinical practice protocols for the nursing staff, which included an oral assessment tool and guidelines for care. The council also standardized oral care products across the institution and instituted electronic documentation for the oral assessment tool as well as the interventions, which we felt was really important. And then finally, we established oral care champions for all inpatient units. The champions are the core members of the Oral Care Council, and they educated the nurses and the patient care technicians on our standards, the assessment tool, and the care guidelines, with some support from the chair of the Oral Care Council as well. So here you can just see our mission and vision for the council. The mission of the council is to ensure quality evidence-based oral care practices are provided to our patients, and we're an interdisciplinary team, and we serve as a resource, and we provide professional guidance, mentoring, and compliance monitoring for clinical oral care practices. So I'd like to give a brief overview of the education that we provided to the nurses when we initially implemented our clinical practice protocol at the institution. We began this education in 2007, 2008, and we've definitely revisited it with staff as needed since. So what you see here is an overview of the education that we provided to nurses on the process of conducting an oral assessment. The oral assessment that we do is completed on admission, every shift and as needed, and we review proper precautions. We talk about positioning, risk factors the nurse should assess for, as well as signs and symptoms of infection. And this right here, what you see now, is the tool that we use to score patients' oral assessments. It's adapted from SAGE's oral care assessment scoring system, and we actually had this tool integrated into our electronic health record, which we thought was critical for bringing awareness to oral care and for ease of documentation by the nurses. So there are 5 domains, as you can see here: teeth, lips, tongue, oral mucosa, and saliva, each with a score range of 1 to 4. and we categorize the patient's assessment as normal for a score of 5, moderate dysfunction for a score of 6 to 10, and severe dysfunction for a score of 11 to 20. And then this table shows our oral care guidelines that we educated the nurses on. So the guidelines are adapted from SAGE's oral cleansing recommendations, and as you can see, for a score of 5, oral care is performed 2 to 3 times a day, so that's for a normal score of 5. And for patients with scores greater than, equal to or greater than 6, the nurse implements oral care about every 2 to 4 hours. So after implementing these tools, we wanted to track compliance with our oral assessment and guidelines as a quality improvement measure. Electronic documentation for the assessment score and interventions was instituted in 2008, and after that, staff were educated on this new documentation system. And then in 2009, we started collecting data. So the chair of the Oral Care Council, as well as the Oral Care Champions, began to audit the nursing documentation compliance for all the patients admitted to the institution. When documentation was not compliant, the champions or the chair of the council would re-educate the staff. So what you see on this slide here is the documentation compliance for the admission note from 2009 at the bottom in blue to 2012 at the top in purple. And it took until 2011 for documentation to routinely be greater than 95% compliant. So this slide shows a graph of the documentation compliance for the oral assessment completed every shift, so that's twice a day for us, and it's completed as part of the physical assessment. And again, by the end of 2011, there in green, you can see that we were more than 95% compliant with documentation routinely. And then finally, what you see here is the documentation compliance for interventions. So documentation was deemed compliant if it reflected the appropriate care for the assessment score given, and again, we were greater than 95% compliant by 2012. So once documentation compliance reached greater than 95% routinely, we wanted to look at patients who had scores of 6 or greater on admission and see if they had improvement during their stay. So we reviewed admission scores for 5,703 adult patients admitted between April 2011 and October 2012. And then we reviewed the discharge scores of patients who were admitted with high scores to see if there was an improvement over the course of their stay. So this chart here shows the admission scores of those 5,703 patients. You can see 86% had admission scores of 5, which is normal, and 14% had high admission oral assessment scores between 6 to 20. So we were interested to see what happened to the oral status of patients who came in with high scores, so over the course of their stay when they were receiving care based on our guidelines. So this graph shows the discharge oral assessment scores of the 14% of patients who are admitted with scores between 6 and 20. This is approximately 798 patients, and you can see that about 80% were discharged home with lower scores, 4.5% went home with the same or higher scores, and 15% expired or were transferred to hospice care. So that data gives you an idea of where we stood, I guess, after implementing the standardized oral assessment tool and interventions in the 4 years following, and we have improvement by discharge and assessment scores of about 80% of patients who were originally admitted with high scores. So although we've standardized practices and achieved good compliance with the assessment tool and the interventions, we still have more work to do for sure. We, of course, want to continue to promote widespread knowledge of oral care through education and leadership. We also want to continue to audit and educate staff and hope to achieve and maintain 100% compliance with oral care documentation. And one area we haven't looked at yet is patient experience. So we'd like to survey the patients regarding their oral care experience during hospitalization. And so far, our focus has been on nursing and patient care technicians education, so we'd like to work with patients and families more directly to help them out. And then finally, we are working to develop an interprofessional program to provide oral care to preoperative patients immediately before going to the OR, so hopefully we can reduce our VAP rates using that. So in summary, over the last 10 years, the Oral Care Council really has brought awareness to oral care and has changed the oral care culture in our institution. So thank you so much for your attention, and I'm going to turn it back over to Corey for questions.
Thank you very much, Hallie. We do have a couple of minutes here for questions, so I want to jump right in so we can get as many as possible here. First question here, what's the best way of performing oral hygiene on a patient who is hospitalized on an anticoagulant therapy? Anyone want to jump in for this one?
Well, this is Kathleen. One of the components that you need to think about is a softer toothbrush if you are going to brush. And again, identifying any challenges that patient may have with potential microaspiration when you're using the cleaning. So can they expectorate or not expectorate to determine whether you would use a non-suction toothbrush or a suction toothbrush, but it would need to be soft.
All right. Thank you, Kathleen. Moving on to our next question. Sorry, go ahead, Ross. Did you have something you wanted to add?
No, I was just going to say that's a fantastic question. Yeah, I mean, you've got to look at, the level of anticoagulation as well. I mean, if you've got someone who has a very, very elevated INR, then that's going to be potentially a problem. But generally speaking, if the INR is in the usual range that the physician wants the patient to be at, it's not going to be an issue. And as you said, as long as a very soft toothbrush is the best way to go, and so you don't irritate the tissues any more than you have to. That would be the only other comment that I would have. If you have a very elevated INR, then that potentially becomes a problem, particularly in the context of someone who has significant periodontal problems. Then you may have some difficulty to control bleeding. And if you do have any bleeding, cold gauze compresses really work extremely well to control that bleeding in most cases. Thanks.
Perfect. Next here, does the hospital employ a dental hygienist to assist with oral health care?
This is Hallie. I can respond from our perspective. We don't have one, and I'm curious to hear if anyone has experience working with them on the inpatient population.
All right. Anyone else want to weigh in before we jump in? Go ahead.
Well, this is Kathleen. I have not seen it in the U.S., but I have seen it in Japan, where dentists and dental hygienists have been working with ICU staff on improving oral hygiene in that patient population, but it's on a limited basis.
Okay. Perfect. So I'm actually going to jump into our last question here, and if anyone has any other questions they want to type in, I believe our presenters here are going to do their best to reach out to anyone who has any other additional questions via the email you've used to register for this webinar. But our last question here, is CHD used outside ICU on non-vented patients, and what is the criteria?
It is used, at least in the recommendation from a science perspective. Most of the time what you'll see is pre-op surgical prep for open heart surgery, where they will do a CHG rinse. My understanding is there is a large multi-center trial getting ready to start looking at different types of oral hygiene for non-vented patients because of it now being the #1 infection in the U.S. And so there is some preliminary data that was published in Nursing Scholarship. Barbara Quinn and at her facility and a couple other facilities have done quality improvement projects of before and after, and have not including CHG, but just a comprehensive oral care program including denture management, and have now reached roughly a 70% reduction in their hospital-acquired pneumonia rate, focusing specifically on a comprehensive oral care. So.
All right, thank you. So that is unfortunately all the time we do have for today. On behalf of Niche, I would like to thank you all for joining us today and for your participation. I'd also like to thank all of our speakers today for their excellent presentations as well. When done with this webinar, be sure to complete the evaluation located in the Niche Knowledge Center. The evaluation is necessary for you to receive your certificate. And also, if you have any additional users participating, we had a few folks asking about that, who do not have accounts in the Knowledge Center and did not individually register for the webinar that need their CEU certificate, please send the name of all participants, including their email addresses, name of this webinar, and name of the hospital to support@nicheprogram.org. Again, so the name of the email address is support@nicheprogram.org, and the webinar to reference this is Oral Health in Older Adults in Acute Care Settings. Users will then be added to the Knowledge Center and prompted to take the evaluation to obtain their certificates. Again, thank you. Afternoon, and you may now disconnect.